Hello everyone, welcome back to our channel. I'm Dr. Ashmita. Today, in this video, let's continue with the chronic viral hepatitis with its clinical features and investigations. So, beginning with the clinical features of chronic viral hepatitis can be segregated into asymptomatic phase, symptomatic, extrahepatic manifestations, and the late complications. Firstly, let's see the asymptomatic phase. Asymptomatic phase is the most common phase. Asymptomatic means it does not have any symptoms. Asymptomatic, no symptoms. There are no symptoms in this phase. So, how is it diagnosed? It is an incidental finding. Incidental, by chance, it is found out by chance during routine blood tests or during the blood donation. The patient, he does not have any symptoms during routine blood tests or during blood donation. When investigations are performed, the deranged liver function test might suggest, it might be suspicious of this chronic viral hepatitis. Upon later investigations, the diagnosis will be made. So it is an asymptomatic phase because it is an incidental finding. It does not have any symptoms. Why is it asymptomatic? Here initially there is only mild inflammation. There is only mild inflammation of the liver. Mild inflammation means there will be only mild hepatocellular dysfunction. Hepatocellular dysfunction. So there are no systemic manifestations. There are no systemic manifestations because of which there is no symptoms. No systemic manifestations means no symptoms in the patient. Therefore, it is asymptomatic and it is only an incidental finding. Coming to the symptomatic phase, in the symptomatic phase, initially there is malaise, fatigue, low-grade fever, that is generalized weakness, malaise, fatigue, low-grade fever. All these are because of release of interleukin 1 and tumor necrosis factor alpha. Interleukin 1, TNF alpha, which are the cytokines released during inflammation. So, in chronic viral hepatitis, there is inflammation, ongoing inflammation, because of which cytokines like interleukin 1, TNF alpha are released. These two are responsible for the malaise, fatigue, and low grade fever. Later, anorexia, nausea, and weight loss develops. Anorexia means this loss of appetite, and there is nausea and weight loss because of loss of appetite. All these are attributed because of this hepatocellular dysfunction. Hepatocellular dysfunction will alter the metabolism. It will alter the metabolism and appetite control. And appetite control. So, altered metabolism and appetite control will lead to this anorexia, that is, loss of appetite, nausea, and weight loss. And there is right upper quadrant discomfort and pain. It is because of hepatomegaly. In chronic viral hepatitis, as we have discussed in the gross features, there is like enlargement of the liver. There is enlargement of the liver because of hepatocellular swelling. So, liver enlargement, hepatomegaly, will lead to stretching of the outer capsule. What is the outer capsule? Gleason's capsule. So it will lead to stretching. It will lead to stretching of Gleason's capsule. Lead to stretching of the Gleason's capsule. Because of this stretching, the pain receptors get activated. That is responsible for this right upper quadrant discomfort or pain. It is because of stretching of the Gleason's capsule because of hepatomegaly. And there is intermittent mild jaundice. Why? Because hepatocellular dysfunction. In chronic viral hepatitis, the hepatocellular injury occurs. Hepatocellular injury occurs because of which there is defect or impaired conjugation, both conjugation and excretion into the bile of what? Of the bilirubin. So because of this accumulation, there will be accumulation of bilirubin in the blood. Accumulation in the blood that will lead to mild jaundice. So in chronic viral hepatitis, there is necrosis. of hepatocytes, because of which conjugation does not occur. Because of necrosis, conjugation does not occur. And whatever the surviving hepatocytes are there, they will conjugate, but because of inflammation, because of the inflammation, the biliary canaliculi will be blocked. So therefore, the conjugated bilirubin are unable to excrete into the bile. So all this unconjugated and the conjugated bilirubin will be pent up, it will accumulate in the blood, because of which there is mild jaundice. Mild jaundice is because of defect in conjugation and excretion because of this hepatitis. And there is hepatomegaly. We have discussed a lot in this acute and also in chronic viral hepatitis morphology also. There is hepatocellular swelling, that is ballooning degeneration, hydropic changes, because of which there is hepatomegaly. It is because of inflammation, inflammatory cell infiltrate will cause hepatomegaly. Because of hepatocellular swelling, there is hepatomegaly. And there is splenomegaly. Splenomegaly is because of portal hypertension. It is because of portal hypertension. Why there is portal hypertension? Portal hypertension is because of fibrosis. In chronic viral hepatitis, when it progresses further to fibrosis, the bridging, we have discussed in morphology, the bridging fibrosis and the regenerative nodules, the bridges and the regenerative nodules are present. The bridges will destroy, it will not allow the regenerative hepatocytes to receive blood supply. The blood supply is totally cut off. That means liver is unable to receive the blood supply. So because of which the portal vein, the supplying vein to the liver is the portal vein. The portal vein, blood stasis will occur. Blood stasis occurs, because of which hypertension is present. So this is called portal hypertension. Because of this portal hypertension, liver is not able to receive, it will backflow. So it will backflow. For example, this is the liver, it receives through portal vein from the spleen. Because of this bridging fibrosis, liver is unable to receive blood supply. It will occur, stasis occurs in the portal vein, because of which there is portal hypertension. Now where will it go? It will backflow into the liver, into the spleen, because of which there is splenomegaly. So splenomegaly is because of portal hypertension. It is due to portal hypertension. And there are spider angiomas and palmar erythema. So there is hepatic dysfunction, chronic viral hepatitis. The function of the liver goes down. The function of the liver is to metabolize estrogen also. So the estrogen metabolism is impaired, because of which this rise of estrogen cutaneous, will cause cutaneous vasodilatation. It will cause cutaneous vasodilatation, and that is responsible for the spider angiomas. So here in the skin, grossly you can see these are the dilated blood vessels in the skin which take the shape of a spider. So these are called spider angiomas. And also in the palms there is erythema of the palms. So palmar erythema and spider angiomas are because of impaired estrogen metabolism. So increase in estrogen will cause these symptoms. And there's easy bruising and bleeding gums. This is because of this loss of synthetic function of the liver. The synthetic function is to synthesize clotting factors like especially 2, 7, 9 and 10. These are the clotting factors synthesized by the liver. So because of liver failure, that is the synthetic activity goes down, clotting factors are not produced, because of which this easy bruising and bleeding gums, bleeding tendencies increase because of loss of synthetic function of the liver. And there is peripheral edema and ascites. Peripheral edema is because of again loss of synthetic function. What synthesis? Protein synthesis. So this decreased protein synthesis. Decreased protein, most commonly hypoalbuminemia. Mainly albumin. Albumin synthesis goes down. Because of hypoalbuminemia, there is peripheral edema, and ascites is again contributed because of portal hypertension. Portal hypertension. So because of this bridging fibrosis, the blood supply is cut off. So stasis of blood occurs in portal vein, portal hypertension, splenomegaly. Because of portal hypertension, there will be like transudate. So there's leakage of fluid from the splanchnic capillaries. So it will lead to transudative ascites in the abdominal cavity. And there is pruritus. Pruritus means itching. It is because of deposition. First of all, there is impairment, there is impaired excretion, this impaired excretion of bile, this impaired excretion of bile, because of which the bile salts will accumulate in the blood. Bile salts will go into the blood. From there, it will get deposited in the skin. It will get deposited in the skin. They will stimulate the nerve endings. They will stimulate the nerve endings. So, because of which there's pruritus. Pruritus is because of deposition. It is because of deposition of bile salts in the skin which stimulate the nerve endings and cause pruritus. This is about the symptomatic phase of chronic viral hepatitis. Generalized symptoms: malaise, fatigue, low-grade fever, anorexia, nausea, weight loss because of altered metabolism, appetite, right upper quadrant pain because of stretching of the capsule, mild jaundice because of hyperbilirubinemia, hepatomegaly, splenomegaly because of portal hypertension, spider angioma, palmar erythema because of estrogen metabolism, easy bruising, bleeding gums because of synthetic function goes down of clotting factors. When protein function goes down, the albumin goes down, peripheral edema. Again, because of portal hypertension is ascites, and pruritus is because of deposition of bile salts in the skin, which will stimulate the nerve endings. Coming to the extrahepatic manifestations of chronic viral hepatitis, the extrahepatic manifestations are most common in hepatitis C virus. HCV is the most common. It is the most common, but it can also occur in hepatitis B virus. So, what are these renal manifestations? The renal manifestations are membranous glomerulonephritis and membranoproliferative glomerulonephritis. Membranous glomerulonephritis more common with hepatitis B virus, whereas membranoproliferative is more common with hepatitis C virus, and it is because of immune complex. It is because of immune complexes formed in this infection. These get deposited. They get deposited in the glomeruli. Because of immune complex deposition in the glomeruli, there is membranous and membranoproliferative glomerulonephritis. Coming to the hematological manifestations, because of this chronic hepatitis C virus, it is like chronic. 80% of the patients are carriers and they have this more tendency for chronicity. The infection doesn't go away easily. There is viral persistence. Viral persist, which will persist. It will act as an antigenic stimulation. It will act as an antigen, because of which the B cell is continuously stimulated. B cells are continuously stimulated. B cells function is to synthesize the from the through plasma cells. It will synthesize immunoglobulins. Immunoglobulins are these cryoglobulins. Cryoglobulins are nothing but the immunoglobulins, and they precipitate at cold temperatures. They precipitate at the cold temperatures. This is mixed cryoglobulinemia due to chronic hepatitis C. In chronic hepatitis C, because of persistent antigenic stimulation, the B cell will continuously get stimulated. They produce immunoglobulins, which are nothing but the cryoglobulins that get precipitated at the cold temperatures. This is about the hematological manifestation of chronic hepatitis, specifically HCV virus. Coming to the endocrine manifestations, that is the hormonal manifestations, because of this immune mediated antibodies are produced that will destroy the self antigens of thyroid. There will be thyroiditis, and they can destroy the beta cells of the pancreas, manifesting as thyroiditis and diabetes mellitus. That is because of self reactive antibodies, because of self reactive or cross reactive. You can say cross reactive, because of cross reactive immune complexes. Because of cross reactive immune complexes, they get thyroid tissue diabetes mellitus will manifest. And in the skin manifestations, there is vasculitic rashes and lichen planus because of deposition of immune complexes in the blood vessels and skin or the mucous membranes. skin mucous membranes. So vasculitic rashes, lichen planus. Vasculitic rashes, lichen planus are the skin manifestations of chronic hepatitis. Coming to the rheumatological, that is the joint manifestations, there is arthralgia and arthritis. These are the immune mediated inflammation. These are immune mediated inflammation. Because of immune mediated inflammation, the joint inflammation is seen. And in the lymphoid, there's increased risk of B cell lymphoma. Again, the reason is same like the mixed cryoglobulinemia. In HCV, because of this viral persistence, viral antigenic stimulus will be present, which will continuously activate the B cells. Continuous proliferation of B cells will lead to B cell lymphoma. It will lead to B cell lymphoma. So lymphoid manifestations is B cell lymphoma. This is about the extrahepatic manifestations, more common with HCV, also seen in HBV. So coming to the late complications, the late manifestations or the late complications of chronic hepatitis are if they are untreated, if the chronic hepatitis it is untreated, it will progress to cirrhosis. Cirrhosis is the total, all the fibrosis that we have studied in the morphology, the bridging fibrosis. Because of this cutoff of blood supply, everything will collapse. The regenerative nodules, all the cells, the bridges, everything they collapse. Because of which there is cirrhosis. Cirrhosis occurs and hepatic failure. And there is esophageal varices, splenomegaly, and ascites. All these three are attributed to portal hypertension. All these are the sequel. They are the sequelae of portal hypertension. Because of portal hypertension, there is backflow of blood to spleen. It will lead to splenomegaly, and there is transudative fluid leakage from the splanchnic capillaries into the abdominal cavity, leading to ascites. And because of portal hypertension only, there is esophageal varices. All these three are the attributions of portal hypertension seen in chronic viral hepatitis. And hepatic encephalopathy is a late complication because the liver loses its detoxification function. Liver has a detoxification function. Detoxification means what? Ammonia is produced. Ammonia is a toxic product. It gets detoxified by entering the urea cycle in the liver. When the liver function is lost, the urea cycle will be lost. Ammonia is not detoxified. Ammonia levels will increase in the blood. It will reach the CNS. After it reaches CNS, it will cause the ammonia's toxic product causes hepatic encephalopathy because of loss of detoxification function. And HCC, there's a risk of hepatocellular carcinoma. We have studied in acute viral also. Hepatitis B, C, and D, they have like chronicity. So more the exposure, higher the risk of HCC, specifically with HBV. Hepatitis B virus, the genome, it will integrate it will integrate with host genome, with the host or the hepatocyte genome, that is the liver cell genome. It will cause hepatocellular carcinoma over time. So these are the late complications of chronic viral hepatitis. So cirrhosis, esophageal varices, splenomegaly, ascites, hepatic encephalopathy, and HCC. These are the late complications of chronic viral hepatitis. Let's move to the investigations of chronic viral hepatitis. Under the routine blood test, you perform liver function test. The liver function test, it shows the increase in transaminases. Why? There's increase in alanine and aspartate transaminases. What are these two enzymes? These two enzymes are the liver cell enzymes in chronic viral hepatitis. In chronic viral hepatitis, there's liver cell injury. Liver cell injury, the necrosis, apoptosis, we have studied whenever there's necrosis, because of necrosis or the liver cell injury, the cell contents leak out. They leak out. The enzymes will leak out. What are the liver cell enzymes? Alanine, aspartate, transaminase. And specifically, alanine is more than aspartate. Why? Alanine is a cytoplasmic enzyme. Alanine is a cytoplasmic enzyme. It is a cytoplasmic enzyme. Whereas AST is more profound in mitochondria. It is more profound in mitochondria. Therefore, in alcoholic hepatitis, AST will be more than ALT. Whereas in viral hepatitis, ALT is more than AST. Though both are raised, ALT is profoundly more than AST because it is a cytoplasmic enzyme. This AST we'll study in detail when we are dealing with alcoholic hepatitis. Coming to the next test, bilirubin. Both total bilirubin and the direct, that is conjugated bilirubin, will be increased in chronic viral hepatitis because of cellular dysfunction, unable to conjugate, unable to excrete. So total bilirubin and the conjugated bilirubin also increases, mainly conjugated increases in because of this impaired impaired excretion or conjugation, because of which this hyperbilirubinemia. And ALP, that is the alkaline phosphatase. I have discussed this in the chart 6, practical chart 6. Alkaline phosphatase is an enzyme. It is secreted by the cells lining of biliary canaliculi. Biliary canaliculi. So its rise most commonly indicates post-hepatic causes like gallstones or gallbladder obstruction, gallstones or tumors related to gallbladder. So ALP in this case, in chronic viral hepatitis, which is mainly a hepatic origin, the ALP will be usually normal, or it can be slight, very mildly increased. Because of that too, it is because of inflammation. Because of inflammation, there is blockage of this biliary canaliculi, which will lead to mild cholestasis. In such situations there can be a mild increase in ALP, otherwise it will be usually normal in chronic viral hepatitis because ALP is not a liver origin, it is a biliary origin. And there is decrease in serum albumin, liver function will go down. So synthetic function, that protein function, synthetic function will go down. Mostly it is albumin. Albumin function will go down. So there is hypoalbuminemia in chronic viral hepatitis. And prothrombin time. What about this coagulation studies? Prothrombin time, it will be prolonged. Why again? Because of these clotting factors. The clotting factors will go down. Again, it is related to synthetic function. Clotting factors 2, 7, 9, 10. It will go down. So prothrombin time will be prolonged. And globulins are raised because of polyclonal B cell activation. As I have said, in chronic viral hepatitis, because of this antigenic stimulus, the B cells are constantly active. So there is polyclonal B cell activation. Polyclonal B cell activation. That is, variety of immunoglobulins are synthesized. We have studied that it has a variable region. So it produces multiple, like variety of immunoglobulin, that is polyclonal B cell activation. So it will lead to the immunoglobulins. Immunoglobulins are nothing but the globulins. So globulins are raised. Globulins are raised in chronic viral hepatitis. Therefore, what will be the albumin globulin ratio? Here albumin will go down, protein will go down, globulins will be increased. So albumin by globulin ratio will be reversed in chronic viral hepatitis. Albumin, the protein will go down, globulin will be raised because of B cell activation. The ratio of A by G, albumin by globulin, will be reversed. This is about the routine blood test. Coming again to the serology, we are dealing with hepatitis B, C, and D. Chronic is dealt with B, C, and D. So, see the structure of hepatitis B virus. It has a surface antigen. This is a surface antigen. These are the surface antigen. Inside, it has an envelope antigen. And also inside, there is a core antigen. The core antigen. So whenever there's infection with hepatitis B, the surface antigen, the envelope antigen will be seen in the blood. The core antigen will not be seen in the blood. It is present to the core of the virus. It will not come out into the blood. Only the surface, the envelope will come out. Therefore, in chronic or acute hepatitis, we have dealt in the acute viral hepatitis video of lab investigations. Now I'm dealing only with the chronic. In chronic, we'll find the hepatitis B surface antigen will be present, hepatitis B envelope antigen will be present, and core antigen will not be manifested. Only the antibody to it, anti-hepatitis B core antibody will be manifested. Since it is chronic, Immunoglobulin G is present. In chronic, immunoglobulin G is present. So repeat after me. In chronic hepatitis B, what are the viral markers? Surface antigen, the envelope antigen, the core antigen not present, antibody is present, anti-HBC. Because it is chronic, it is IgG. C, chronic is C, make it G, IgG. IgG is present. Similarly, for hepatitis C virus, you find the immunoglobulin G against the HCV. So it is anti-HCV immunoglobulin G. Anti-HCV immunoglobulin G. Similarly, for hepatitis D, you will find immunoglobulin G, anti-hepatitis D virus immunoglobulin G. So anti-HDV IgG. So these are the markers in case of chronic hepatitis B, hepatitis C, hepatitis D. This is the serological markers. Coming to the imaging, so imaging we can do ultrasound done to assess the gross enlargement or the gross findings of the liver, fibroscan to assess the degree of fibrosis, CT and MRI abdomen done to know the soft tissue architecture or parenchymal changes. For that reason, we can perform a CT MRI. Coming to the liver biopsy always biopsies are gold standard. So gold standard for diagnosing or grading and staging the disease. So in our previous video, we have dealt with the morphology, we have studied the histopathology. All those are because we have done liver biopsy. On liver biopsy, if you do a liver biopsy, only you can study the histopathological changes. So liver biopsy is a gold standard and it will demonstrate what we have studied in the previous video. Portal inflammation, lobular inflammation, the interface hepatitis I have said about the piecemeal necrosis, and there are fibrosis, the bridging fibrosis that we have seen on mesenteric stain. All this inflammation can be like demonstrated on a liver biopsy. Other supportive tests include the alpha fetoprotein, which is a tumor marker for this HCC. If you are suspecting a HCC because it is a chronic case and it has a prolonged duration, if you are suspecting HCC in that patient, you can perform an alpha fetoprotein marker, which is a tumor marker which is increased in hepatocellular carcinoma. And also, if all the serological markers are negative, to exclude autoimmune cause, to exclude autoimmune hepatitis, you can perform an autoimmune panel, which includes anti-nuclear antibody and smooth muscle antibody, which are mostly positive in type 1 autoimmune hepatitis. So when the serology comes out to be negative, but all the symptoms are going towards hepatitis, you can do to exclude autoimmune cause, you can do autoimmune panel, which includes ANA, SMA, and routine CBC. CBC, there will be thrombocytopenia. Why platelet count goes down? Because of portal hypertension. Whenever there is portal hypertension, backflow of blood to the spleen, there will be splenomegaly. There will be splenomegaly. The enlarged spleen it will trap more platelets. So enlarged spleen will trap more platelets, more lysis of platelets, therefore thrombocytopenia. The platelet count goes down because of portal hypertension or splenomegaly. And coming to the serum ammonia, because the detoxification function goes down, ammonia levels rise in the blood. It is seen in hepatic encephalopathy. In hepatic encephalopathy, when you do a serum ammonia levels, it will be obviously be raised because of detoxification function goes down. Later, for the follow-up and monitoring, we can assess the viral load by doing this PCR or RT-PCR, which directly like measures, it quantifies the HPV or the HCV DNA and RNA. It will directly quantify viral genome. For hepatitis B DNA, HCV it is RNA. It will monitor the response to treatment, and you can also measure or monitor the LFT over time. Serial LFT monitoring can be done to know the trend, how it will reflect the improvement or worsening. When you start the treatment, is it improving or worsening? You can monitor by this LFT. And ultrasound AFP can be done every 6 months to screen for HCC in cirrhotic patients. Cirrhotic means it advanced, so he may again progress to HCC. To screen for HCC every 6 months, we can do a ultrasound and AFP monitoring. So this is all about the clinical features and the investigations regarding chronic viral hepatitis. So in our next video, we'll deal about the grading also. So stay tuned to our channel. If you like this video, please like, share, subscribe, and Thank you, everyone.